And what I'm going to cover is a bit of a history of sleep medicine and some of the changes that we've lived through and where I personally feel like the field is going. And I think a lot of you will agree with at least some of it. At this point in time, I'm in a state where Blue Cross is not forced home testing on us, and so we're actually building in lab beds. So it's really weird. Having come from Georgia and from Chattanooga, it's very foreign to me. I've only been there 7 months, but it's a very eye-opening experience. I don't have any disclosures to reveal. Again, on me. Presentation objectives today to describe and enumerate what I had in this article that I spoke about the evolving role of the sleep technologist. As many of you know, through home testing, most of what we're left with in the lab now are the most fragile and brittle patients. And we want to make sure that we have great staff and understand where all this is going. Want to acknowledge the impact of technology and distinguish between where the field has been and more of a diagnostic focus versus an outcomes focus on the field and some of the limitations that have been realized along the way. This next to last comment down here about the credentials and education skill set necessary to perform sleep medicine as a technologist in the lab in the future. We'll spend a few minutes on, and then near the wrap up and summary, provide what I think is a glimpse of sleep medicine or may have already come to the lab. Honestly, many of us are dealing with more complicated patients, and thank goodness for folks like Byron. Every time I hear Byron's presentation, I learn something new. And I bet you I've heard that same presentation probably 6 or 7 times since 2010. And it's just something I learn from every time I hear it.
Yeah, I don't think.
Okay, so if a lot of y'all with white and gray hair, just y'all started at a place where I did with a Neuropac 4 or Neon Code or some machine that had an inkwell on the right, maybe without a photostimulator, and a paper tray on the left. And every time you took a break, came back from having a cigarette or getting a Coke out of the vending machine, respiratory, getting your break, and paper was, all out before and everything. So it really had to be a jack of all trades back here in the early 90s and 1980s, because what we'd taken weren't always true polygraphs. They were polygraphs in the sense that they worked and were utilized in a sleep lab, but they were also at the core EEG machines that had oximeters, plasmographs, just all kinds of ancillary devices adapted and typed into it. And it was your job to keep them going throughout the night. And so the titration of your CPAP for the care of your patient for the first half of the night often became secondary to keeping the machine running and keeping all the ancillary parts moving in the oximeter printer, if y'all remember that, in sync with what was on the actual paper with the EEG signals on. So we've come a long way since then. But I wanted to give a quick rundown of where and how my career has progressed, what all I've kind of lived through. And we're going to take you back to, if you can see this, the beginning of CPAP, really, for anybody who doesn't know already. Dr. Cullen Sullivan first fielded CPAP in 1980, and over the years, in this country at least, and in Australia, we began to see emergence of sleep labs at big teaching universities like Stanford, Emory, Vanderbilt, and so forth. And as I tell people about my career who don't know it, I'll explain that sleep primarily as a discipline began in the West and moved east. Most everybody here is familiar with the Atlanta School for Sleep Medicine. Atlanta probably came online in the late 1980s. Many folks actually went through that training and other training that was provided. But At this point in time, technologists and technicians were mostly trained OJT. There were review courses for staging and scoring, for board preparation. And most of y'all in here remember the time where, the board exam preparation materials outside of a conference like this was 5 or 6 medical texts. That was it. And possibly respiratory school if your state required that you also hold respiratory care license. So as we moved along, there was really not the congealing or the coming together of the formal education that we wanted, that we expected. Most of the people that have respiratory training degrees in here may have experienced this as respiratory came into its own in the 1980s and 90s, where sleep thought it was going to go by then, that there would be an associate's degree required, and there would be much more formal training so that you knew if you or your loved one went into a sleep lab, despite ASTAP and despite all these training modalities that we have now, you would be getting care from somebody who knew exactly what they were looking at. And so that's kind of been the challenge that we've had along the way is standardization of training in the midst of lots of technical development and lots of, at this point in time in the early 90s, shortages. There was only about, my registry number is 1,200, so by 1995, there was still less than 2,000 registered techs worldwide. I worked and was hired by a guy that was age 72. Kevin, your number is probably before that, I can't remember. But, there's a lot of folks that, started very early and were all self-taught on top of respiratory training. So that, and especially where I work now, is just a very comforting feeling if you're a coordinator or a manager of the lab when you're home at night. So, advance a little bit to the early 2000s. The VRPT at this point had replaced the 3-part registry with a 1-part, exam setting, and the number of techs has grown into the tens of the thousands worldwide. PC-based polysomnography is everywhere. One of the earliest systems that I worked with, most of you at some point or another probably used, was the old Alice system. It was a kind of an industry standard in the early 90s, it seemed like. Davis and others came along and made their impact. But these new digital platforms, I call them digital, but computer-based workstation platforms came along, the need for expertise and instrumentation began to dwindle. We had fewer and fewer folks jockeying for day positions or day scorer positions. We had more and more with the look-back feature, techs being able to score on the fly in many labs. And that's the standard now. And it was at this point in time that the physician-based labs exploded. The hospital-based labs were always there, but the physicians saw how much money they could make, and the proliferation of standalone labs just ran wild for the next 10 years. And so what you had at the end of about 2005, where the ASM rolls out ASTAP, somewhere in the mid-2000s, you had this huge Medicare audit of sleep utilization, of sleep medicine utilization. And so concurrently, you had the 2005 white paper about home testing coming out. So Medicare at that point, those of y'all have worked at DME, the hard and fast rules about the face-to-face meeting within 90 days, 30 days of sleep test equipment, everything tightened up on getting that. So there's a lot of change around regulations and education coming all at once when we thought it really at the peak of in-lab testing, parts of it began to chip away. And in 2011, when I was at Piedmont, Atlanta, Georgia, is anybody here from Georgia? One, okay. But the state of Georgia's insurance companies were the first to roll out the mandate for home testing. And so that closed a lot of beds that never reopened again. So we had kind of an emergence, or a convergence rather, of the last decade of proliferation with the insurers slamming on the brakes. At the same time, we're trying to build a labor pool of folks that are better trained, better credentialed, have been through 80 hours of didactic training. Paula and I ran Tennessee Academy for Sleep Medicine 2007 to 2011.
Your first one, so
And Cassie back there really is actually our first graduate. And she's now working sleep, right?
Sleep and
Okay,
eat.
have been done good, both sleep and EEG. And she came to us when she was 18 years old.
Just graduated high school.
And literally walked in with medical terminology and all the rest of the other 8 hours of training. At that time, the 30 modules or whatever it is, the online modules, I don't think had been added, but anyway, she's recertified every 5 years and passing the registry. Also registered in EEG. But the point is, training began to be standardized as we saw additional states take on licensure. The qualifications become more and more important because of some of the things that had happened in these physician-owned labs, where doctors, standalone labs, would take people that have been drawing blood one day, maybe a few unauthorized PFTs, and all of a sudden they're running night studies and doing sleep titrations. You've heard of this one. And so the doctors at that point in time, for the most part, were seen as greedy by the insurance companies. This is part of what forced home testing in many states, especially when I lived at the time. So they'll become disconnected. Okay. The not only have I become disconnected here, disconnected on the somebody can step out there and has Zach to set back in with the lady who was with him. All of a sudden, that's some pros here. What I'll do is slide into
Disconnect.
so the last 10 years since 2008, or 13 years, more and more people have become registered. Right now, worldwide, there's probably 29, 30 plus thousand registered by the BRBT. And of course, at this point in time, the ASM or the ABSM rolled out the RSC credential, and then in 2013, 2014 time frame, the CCSH credential was rolled out, frozen both here and there. And so now we have all kinds of folks that are qualified, but our in-lab volumes are shrinking, continuing to shrink. Now, thank you. Not sure what I did. Again, this back I just did in June. The one leading question that I finalized the interview with was, what do you think the sleep lab is going to look like in 2031, 2032? He quite quickly replied, like a small scale ICU. And if you haven't already seen some of this, you will. I worked prior to Tuscaloosa at the lab at Fannin Regional Medical Center in Blue Ridge. And in a more rural setting, the patients there, I don't know if rural has anything to do with it or not, this happens to be for this lab, are more complicated patients, possibly because they're coming from a pulmonologist. But as you get the lab filled up with people that has only comorbidities, then night to night, you want to make sure your folks qualify and know what they're looking at. And Krager was very kind, called me back the same day, agreed to an interview, the very same day I emailed him. So it has a little Yahoo account. So now, by the end of the 1990s, we again expected that there would be at least some degree requirement for techs so that we could discern exactly what they knew. We knew the respiratory folks had A&P, microbiology, so on and so forth, all the respiratory core classes. You look around, except for the curriculum A-step, and then the RSC credential, and then of course the SDS add-on credential for respiratory. You kind of know what the skill set is, but you don't know how somebody can apply it or what they can really do until you got them, until you hire them. Half my career has been spent, probably about 55% of my career in patient care, the other 45% in a management role. And I can tell you over the years, as I'm sure that some of y'all seen, Nashville and other places, that the person that was registered in the 1990s you kind of knew more of what you could expect. Now that the exam changes the way it has, it's not, so predictable. And the reason I mentioned this is that I think with a standardized, 2-year program, which was offered in a few places, but rather than just a 12-month certificate, you would have a better idea that, okay, this person sure has had AP, they've had microbiology, they've had medical terminology, passed, some basic terms, and just, could accelerate your in-lab orientation to the point that you don't have to have it drag out quite so long. So we measure, compliance, we measure cost savings, and we have been in the business of diagnosing for many, many years. And now that we're being focused on by Medicare and other parts of the system, particularly hospital administration, or what can you do for me, these outcomes become very important. Part of this presentation has been concluded by talking about sleep educator, sleep navigator goals, and how we can help demonstrate some of those outcomes by shortening length of stay, decreasing the cost of taking care of undiagnosed patients versus those that are diagnosed when coming to the hospital, and preventing those 30-day readmissions where the hospital has to pay back money, gets no further money for the same readmission, the same diagnosis. Okay, those more complex patients. I pirated this off of one of, I believe it was Byron's slides. And so you can see here, this is somebody who's just, very typical of what we have now. And often for the remainder of our careers, at least, and into the next generation of sleep techs. These kinds of patients have a presentation that requires, some demonstrable level of skill. And it's nowadays, I would argue that skill is much higher place than it was in 1995, 1994, or even 2004, because of the impact of home testing. And all these folks with these comorbidities being the only ones let into the labs in most states. Okay, so what may things look like 10 years from now? This is just my personal estimate based on my time in Georgia. So just over half of heart failure, hypertension, post-CABG patients, people that have got coronary artery disease, folks that have got AFib, it's not listed there, but that's certainly part of that group. Stroke, other comorbid conditions such as maybe chronic kidney failure. 80% of those folks have sleep apnea, function with hypertension and other factors, or overlap syndrome, diabetes, chronic kidney failure, obesity, and sleep apnea and heart disease. So this is kind of what we have to look forward to. And in many places, it's arrived 5 to 10 years ago because of mandates of insurance companies. Okay, so what's in red right here is, what I'm thinking is going to be more variable. What's going to change the most? You're going to have some hospitals that have more than 1, maybe 2 or 3 cardiovascular or cardiology groups. There's no telling what this percentage may be. And a lot of it depending on relationships, of course, between your physicians and those cardiologists. So more and more of these folks come in, sooner or later, whether you're in a 4-bed lab now, or like I'm in a multi-bed lab, 20-bed lab. I just can't believe it. In Alabama, of course, in Tuscaloosa, there's only 1 hospital. So we've got kind of all the business. And home testing has not been mandated by Blue Cross of Alabama. That's a whole other story. We'll hear that offline. But on any given night, we've got folks going through the door, and they're much, much healthier than all the patients that I ever dealt with in Georgia. These are average patients like the early 90s, except for early 90s. I don't think I tested the first female patient until about 1996 or so, except for maybe an MSLT patient. But the apnea patients were all men. Now, the acuity is going to go up if it hasn't already. In these days of patient-to-tech ratios being recommended by the ASM of 2 to 1, it'll be harder and harder and harder to maintain. As hospital directors, we sit around the table with nursing folks and other folks talk about the floors taking care of ratios of 5-to-1, and they're sick patients. Your patients are ambulatory, walking outpatients. Why can't you take care of more than 2? Well, then we go through the explanation and so forth. We need to look at you a little closer. So it was a joint commission, get into things like medicines and this deeper infection control issues. I think most people are using disposable masks now. But the thing is, the more acute our folks get, the more prepared we need to be and be ready to move on. This is the old slide from 2 or 3, 4 years ago that I like to put in here. It's Henry Ford, if you can't see it in the back, it says, if I'd ask people what they wanted, instead of faster horse. And I throw that up there to remind us all that we're really in a time of change right now. And if you don't know things are changing, then it could be that you're too silent or too busy with the main thing, whatever that is, whether it's scoring or running SLT or running financial systems for practice or what have you. To know that the earth is moving underneath us in sleep. And that's driven by technology. It's being driven by home testing. Dr. Krieger on the phone in June was telling me about some of these gadgets, Apple-based gadgets and devices now that can approximate non-REM sleep. And then, of course, what happens to those folks? If they don't want to come in the sleep lab, get an order for AutoPath. So where does that leave us? I don't know. Where it can leave us, though, for those people who fail AutoPath or come back into the hospital later, it can leave us in a role of coach, an educator. It is a liaison between the nursing staff, the hospitalists, neurointensivists, the pulmonologists, and the discharge planners, the case managers, the people that are going to see to the aftercare of these people that go home. Hopefully, we can avoid, here's another technology that have been positioned on us, it's artificial intelligence. I'm not slamming the company, but who's heard of InsoData? Anybody in here? 1 or 2 InsoData people? And again, whoever's online, listen to this. I'm not slamming InsoData. We've got some actually pretty good work friends there. But to sell artificial intelligence, automated scoring, that kind of thing to your director, what are you doing? To your medical director? Well, if they go for it, first of all, you're working somebody in your lab out of a job. But second of all, if you look at these things, I'm starting to look at it just to see what it is I think I don't like. Some of them are pretty accurate. That's scary. That's really scary because they're getting better and better. But we, in the role that I see in hospital systems, are going to become more and more consultants to the medical staff and to nursing and discharge planning. And in many, well, not many, but at least a few isolated places now, particularly Nashville, I think maybe Knoxville, and certainly Atlanta. And then the smaller hospitals, the directors do this. They have sleep educators go out, sleep navigators, some of them are called. They work with discharge planning to make sure that folks get the treatment that they need, or if they qualify, blood gases or some form, qualification like that, go straight on the BiPAP or something like that. A lot of hospital systems, like the one I work in, are thinking about renting. Just saying, okay, Mr. Sims, here's your CPAP, your auto CPAP, here's how we're able to spend an hour, hour and a half setup with them, just like they would when they buy it. But to put them on AutoPath as they come out of the hospital, whether they've been screened or not. In other words, they don't have to qualify for the purchase. We're just renting it to them with the doctor's order to hopefully prevent them from, having a really bad outcome until they get back into the sleep lab. Some of those patients will also be home tested or have portable monitoring performed while they're in the hospital, but those things fall off and filled with nurses and so forth. Kind of hard to do. But if you look back at the educational requirements, there's a lot of different ways for technologists now to distinguish themselves in this more complicated world we're moving into. Sleep navigators tend to have this CCSH credential. I went out and got it just 2 or 3 months ago. If you've not got it, probably everybody in here can qualify and pass it. And that's not a bad thing. It's a good thing because people, in their role as educators in the hospital and in medical practice of a standalone sleep center, need to be able to advise families, need to be able to coach doctors and give advice like Byron was describing hour before last. of how to read and download, how to advise, next steps for patients to take good care of. So, what I think patient needs to, not patient, a technologist needs to know going forward. First of all, back to the Henry Ford slide, change is inevitable. Things are changing now, whether or not you want to acknowledge it. And if change is not your thing, you need to carefully consider your options. If you're near retirement or if you're just beginning your career, I'm telling the youngest techs in my department, you need to get all the credentials you can, because 30 years from now, I started when I was 28, and I'm now 59. We won't be able to recognize sleep 30 years from now. There's no telling what it will look like. But best prepared, those folks have got to roll with the changes, and obviously best qualified to handle medications, to run the ASV studies and respiratory assist devices. Understand the difference in leak values. I had the first week on my job, I had a younger tech who doesn't work there. She quit on her own. She wasn't dismissed with it. She was reporting on her morning report with a patient. Patient wouldn't get back to sleep, but this, that, and the other. And my leak was only 40. I said, 40. I said, what pressure? What pressure? Pressure's 12. It's a little much. And so, again, this person had been running tests for a long, long time, and somehow getting acceptable titrations. But you have a mixture of folks that are out there working still. But again, I think that the BRPT and other boards like the ABSN and so forth could have leaned a little harder on the industry 20 years ago to require a 2-year degree. Myself, a couple others in this room were just kind of impulsive with education that way. But sooner or later, Medicare may tighten its rules. In 2008, after this audit that I talked about, in addition to the face-to-face interviews and all the DME documentation that has to ensue now, you have to have, a registered tech run your studies. You have to have either that or a CRT or an RRT run those studies. It's in law. You can't get around it. So, what I also tell folks, the last 2 things down here, not so much seizure recognition unless you're running for a neurologist, but certainly you need to be an expert now in cardiac arrhythmia recognition. I don't think that's negotiable. You got, there's an old joke that we had in Chattanooga where the tech called us up one night or called up a colleague in the room and said, I think I've got some BTAC. What's your rate? 68. Because you open page, you look at the book, please, the rate of 68 is not BTAC, it's probably pacer spikes. And so as the tech dug into the ACP, sure enough, pacer spikes. So, you don't want to get that call at 1 or 2 o'clock in the morning and, be looking at out of a coma and then you can't go back to sleep because you're then worried about the other patient that the tech has got that came from cardiology and is 400 pounds of hypoventilatory and so forth. Seizure recognition is something that if you worked in EEG, you may have an eye for. I worked for a year and a half full-time at EEG to get off a night shift in the 90s. So I developed that. I guess that's how, wherever I've been, I've got tagged in neurology also. So what do we hold for the future? No, we're on a limited timeline here, and I think I'm the only person standing between us and lunch. Upwardly spiraling, I think that everybody's probably in agreement with that, except in funny places like Alabama, where I'm working in home testing, I'm enforced. In fact, in 20 beds, 4,500 procedures a year, less than a dozen of those are home tests. It's just miraculous. I came in there, it took 3 or 4 interviews before I believed them. They were telling me I wouldn't do it. I'm testing. Well, I'm testing you. And so one thing led to another, and here I am. But you've got some places a tech glut. In other places, you've got tech shortages. In Atlanta, if you pull up Indeed.com or some other employment website right now, there's jobs paid, not traveling jobs, regular jobs paying $38, $40 an hour for Weight Watchers. The people that just run the tests.
Really?
Yes, and that's before shift differential. But that's without the $10,000 sign-on bonus. Wellstar, Fusion, Fusion, Wellstar, Piedmont doesn't have a silent bonus, but the Atlanta labs was dying for people. We got a call from a friend this last week saying, "Hey, can we put a sleep school back together?" I'm like, because again, you kind of feel like you're on the hook for placement once you start running people through it $3,000 a week like the Atlanta school did. So, increased educational requirements would be great. And I think they're going to be forced by insurance. While we need to focus on patient outcomes, well, we should never have thought of ourselves as a one-trick pony. But now, having been dampened and held back a little bit by home testing, we're starting to look to reinvent ourselves with inpatient screening, helping to quantify our existence with CFOs and other people by helping shorten length of stay, the cost of taking care of people while they're in the hospital. Friend Massey Arrington down in Wellstar in Atlanta got some really good data on this and presented at APSS 2020, yes, last year, 2020. And it was almost all virtual, of course, but he had a slide deck. It was only about 16 slides, but he showed how the beginning of this program, placing these CCSH sleep navigators in different hospitals, had brought down the decrease the cost of care and so forth. And checked his data not long ago, and he shaved a day and a half off the length of stay of all the cardiac patients in the treatment. So, I mean, there's some really quantifiable numbers. It takes a lot of cooperation from the finance people to get to whatever your baseline data is. But once you get there, you can really show some improved outcomes. If you don't already have care orchestrator or other, I don't remember what the ResNet compliance software is, but if you can follow your patients like that and see the yellow or the red come up every day, call them up and run them back in, it'll help your doctor and it'll help their outcomes. So, sure, the stage we talked about, the hospitals and nursing homes and LSACs and everything, they can only go so far. I personally see the role of the sleep educators and the sleep navigators going beyond traditional healthcare. I think that if Medicare was ever appropriately leaned on by the AASM and others to recognize some kind of credential like the CCSH or something like it to pay follow-up visits, and there's isolated cases where people are claimed to be paid for the CCSH folks seeing the follow-up patients, and that turns out has only been in behavioral sleep medicine, where they get payments just like the diabetes educator. But there's lots and lots of opportunities still, but we've just got to tell folks, tell organizations, and promote ourselves like the Henry Ford slide said, what we want and what they want and what we're capable of. So, just here a prior lunch, recap. Starting in the middle there, by 2032, the average hospital sleep lab, not the standalone, but the average hospital sleep lab is probably going to resemble a small scale ICU. There's a multi-specialty group that Paul and I worked at in Chattanooga that on any given night, there was an ALS patient, there was people walking through the doors on 3 and 4 liters of continuous oxygen to imagine. It's somewhat dependent on the specialty of your sleep doctor. If they're pulmonology, obviously your acuity may be a little higher. You may just have an internist with the ABIM certification, but they're great friends with cardiologists. They're going to have complicated patients, but the number of undiagnosed patients is not going well. Depending on your belief in the population, somewhere in the middle is 8% instead of 5 to 15% like Byron said. Just hit it right in the middle and say 8%. That's 27 million people, undiagnosed apnea patients in this country. So we need folks that can take care of sicker patients, with the right attitude. And you see at the beginning of shifts a lot, people cherry pick their patients. The time for that's gone. We've got more to do, especially if patients are coming in. If you don't make those assignments, and most directors or lead techs will make those assignments, but then you go away, you go home at 5 or 6 o'clock, and they come in and they start training. It's a whole other story, but you want your best people and your hardest patients. But the flip side of that is, and I'm trying to get this across my medical record, they're never going to learn how to do a successful ASD if they don't do an ASD. Kind of like driving a car, you want to send your 10 or 15-year-old out on the road. The only way they're going to learn to drive is to drive. So, combination therapies, I think, especially since COVID last year, when people weren't going into the offices, there was, at least where I was at that time, a climb, a very steady climb in the use of oral appliances, positional therapy. Paul was going to talk later today. They have lunch, I think, about the upper airway stimulators and so forth, and there's ending with those where we were with the space race in 1958. I think earlier from the White House, a lot of alternative therapies are being looked at as we lived through COVID, and then this year the Philips recall. There's been a lot of challenges, but again, the common theme there, besides qualification, is adaptability to change. So, if you want to talk after this, I'll be around until tomorrow. I appreciate your indulgence. And again, I feel like I'm preaching to the choir. This is a very seasoned and experienced group. I can tell by looking around and seeing very familiar faces from over the years. So, thank you for your time. One question. Back up.
So, I've been asleep since 2005.
Yeah.
When I first started, I was respiratory.
Yeah.
I was traveling. I wanted a full-time job, and the sleep lab wanted to hire some respiratory people. That's how I got into it. This room was my standard patient.
Now,
But now that this is my standard patient.
is it?
They're
So you've seen that
330
change?
pounds or more. They're on 3 or 4 liters of oxygen. They have neuro problems or respiratory problems. They have to have a caregiver because they can't get themselves out of the wheelchair to get in the bed. No matter how much, I mean, I've had patients had to go home because they needed a Warrior lift to get in the bed.
Yeah, you doesn't have a Warrior lift, you need to get one.
Well, and the thing is how do you can have the best sleep techs with the best education. You can have the best doctor reading your stuff. But if the sleep lab doesn't evolve to help you manage those patients, you have a hotel bed.
That's right.
In a bathroom.
Great beds, you need great equipment.
But how do you can't hardly you can't do 2 of those patients that need that much care.
Well,
And they're all CPAP because they all have
let's
oxygen.
take one patient with a Warrior lift and get a regular patient with another patient. I'll say regular patient.
They're not regular. That's just it. That would be a
Let
nice.
me back up and ask another question about the one with the Warrior lift. How many Warrior lift or immobile, unambulatory patients do you have? Because then you start thinking about fire. Yeah, how are you going to get them out? I'm on the second floor of a medical plaza. My medical director, while I was away for an extended 4th of July weekend, snuck in a nursing home patient. And he and I had words. And like, he said, "Well, you're going to cut yourself out of one rehab patients if you don't take these kind of patients." I said, "God, we're on the second floor. So when you throw them on a mattress and pull them down the stairs, the elevators are turned off, they're fine." So I understand. I mean, it gets complicated, not just for the patient care, but then for alternate and emergency situations.
Well, and also the time frame, we're all a lot of the same ages. I mean, used to, if somebody else put it in the bed, they may go to sleep right in, but you didn't.
I think what you're getting around is staffing, and staffing is going to have to evolve.
2 bed lab. I mean,
2 words, acuity levels.
Yeah.
They have to write, the managers and the directors have to write protocols and policies to send through NBC and executive in order to provide acuity levels, which protect you with the patient, protects the long.
And it could be that those need to be more one-to-one, or you bring out the mid-shift person that circulates and helps get people to bed. Because once they're in bed, most of them may be journals or whatever.
well, and
If
then
they're incontinent, they've got pads on,
when you're sick, so they kind of keep it down. But
Again,
now-
That's up to management to determine this
Yeah.
patient one-on-one.
The most difficult time is the time between the time that they come in, get everybody to bed, and then of course, in the first hour, hour and a half, your CPAP or your tap titration. I get it, I really do, but we gotta figure it out. This is acuity and staff, and it's just, what level are you willing to work with? And when I got back from July 4th and talked to my medical director, I'm like, I need to be involved in this because I'm in the chair, not you. You're getting paid a stipend to be the medical director. You go wherever. I'm the one that's gonna fry, something happens. And I didn't authorize that, I wasn't involved in that conversation. So, we work through these kind of things and stuff, and you decide who you're going to test and who you're not. But then The question is, well, are you going to deny, no, I'm not going to deny treatment. It could be that somebody just needs to get their car and go somewhere. with it. Yes. Yes.